Here's a lecture I just recently gave to my residents about diagnosing CSF rhinorrhea. Now, throughout the talk, I ask questions to them, but you won't hear their answers, but maybe just take a moment, think about how you would answer the questions, and hopefully you get something out of this.
All right, good morning, everyone. Only mild technical difficulties. So we're going to run through diagnosing CSF rhinorrhea. All right, first off, our outline for the morning. We'll talk about pertinent anatomy, etiologies causing nasal CSF leaks, and then the science as well as the art of diagnosis. You're going to find that it's not always straightforward. So anatomy, question time. What are the histologic tissue layers from the sinus mucosa to the brain parenchyma? Start with the mucosa. We got mucosa, you got periosteum, bone, dura with the periosteal layer of the dura, and then what comes after that, everybody? Arachnoid. And then, and in between the two, it's subarachnoid space. I'm going over basics so that we all are on the same playing field as we delve deeper. So, damage to what of those layers will cause a nasal CSF leak? Anthony.
So everything basically below subarachnoid space.
Yeah. So a defect through the mucosa and the arachnoid will have a CSF leak. I bring this up because there are brain lesions that herniate down into the nose, but they don't actually leak, right? So you have to have that mucosal tear. So simple diagram here, but we flip it upside down. And so, yes, that's our bone. This is our mucosa. I'm sorry, that's dura. And then the red's mucosa. Again, simple concept here, but you have to have a defect through arachnoid all the way through the mucosa. All right, we're all on the same playing field now. So in a patient with CSF rhinorrhea, what are the potential sites of CSF leakage? Will, the reason I'm asking this is because I do think it's helpful to think about all the sites where there actually is adjacent dura and skull base where you could get a leak, because we haven't listed them all yet, so I'm just going to help out here. So if you think about this SAG CT here, it gives you most of the sites. So helps to always break things down into sites, right? So within the ethmoid, we'll mention ethmoid roof, or the fovea ethmoidalis, cribriform plate. And then there's the lateral lamella of the cribriform plate, which I'm not showing in this picture. We go over it every year in the sinus anatomy lecture, but that's the bone from the cribriform plate attaching to the ethmoid roof. Okay, so when we take care of encephaloceles or traumatic leaks, each of those three sites, they might seem like they're close together, but the repair is actually a little different. So it's helpful to think about these different areas. Sphenoid, multiple sites. Roof, or the planum. The sella, okay? We deal with CSF leaks there frequently. The clivus, you can get a leak there. The lateral recess. And depending what paper you read, 20 to 40%, it's probably more like the 20. Everything's 20%, so you can usually guess that. It's a not totally accurate statement, but I've noticed that that's a common one when it comes to these incidental anatomy findings. Okay, the frontal, yes, the posterior table. And then, yes, Lane, good job. Someone's thinking about the temporal bone. So you could have a Tegman defect or any defect along it. What's that? Oh, I've got headphones in, so I'm not hearing everything. And then the petrous apex can also, you can have a fistula into the sphenoid sinus. So complications of CSF leaks. Oh my God, I am forgetting your name, man. What? Kyle. Shame me. All right. We met in interesting circumstances last time, so I don't remember everything. Okay. What are some complications of CSF leaks? That sounded weird too, but it was a social gathering amongst Team Rhinology. Okay. So meningitis. Just so everyone knows, when you get a CSF leak, it's not like a automatic, oh, that person's going to get meningitis. We have people living with CSF leaks for years sometimes without getting meningitis, but there's no question there's a risk. And there's this, I don't know, one of the better papers I found, it's actually in the otology literature. They followed people for a long time, and they found about a 1 to 10% risk annually. Another conclusion that about 20% lifetime risk. So that's a legit, if I'm that patient, 1 in 5 chance you're going to get meningitis if you don't repair this. Brain abscess. Pneumocephalus. So this was a patient of ours a couple years ago, tension pneumocephalus. I like it because if people aren't familiar with Mount Fuji, this is the Mount Fuji side. So if you get enough air in the frontal lobe, it tenses the brain back and you get these points here. So those are the big ones. That's why we want to repair these. All right, CSF leak etiologies. How would you classify? It's a very basic classification system in your head for CSF leak etiologies. Good. It's a good basic. And within those, give me more. So etiologies, absolutely. It's good to think about them traumatic and atraumatic. Traumatic's more common on the whole. And in the literature, kind of, I've seen numbers going back and forth, whether iatrogenic or accidental are more common. Atraumatic, so the ones we didn't list, so absolutely spontaneous is going to be the one we typically think about. Some tumors will cause CSF leaks, and then some patients have congenital encephalocele that can leak. So let's spend a little time on idiopathic intracranial hypertension. You mentioned that in the setting of spontaneous CSF leaks. Raven, how would you define this condition, or tell me what you know about this condition? Do you think most of these patients get leaks?
No, but it's like it's no longer about
Yeah. Has anyone read an incidence amongst IH patients of CSF leaks? Jake, have you seen one? Yeah, I haven't either. But yes, intracranial pressure elevation. We won't go through all the mechanisms because, frankly, we don't truly understand all the reasons. But idiopathic intracranial hypertension is the more accepted term currently. Used to be benign intracranial hypertension, used to be pseudotumor cerebri. You're still going to see those terms, so I always feel like you got to know all these terms. But if you want to look like you know what you're talking about, IIH. Okay, so greater than 90% of these patients are obese females in childbearing age, mean 30 years old. But this is the point that I think is important and could even be a board question for you because I know the person who's published a lot about this. That is the mean age for IH, but that is not the mean age for CSF leaks. So this has been shown. The mean age for CSF leaks in these patients is actually in the 50s, which goes hand in hand with this idea of chronic elevated pressure eventually wears through the bone. So that's published by Brad Woodworth if he's listening out there. Most common presenting symptoms, we're just going to fire through this. Headache is the most common. I didn't put the source for this, but it's a neurology paper. If anyone's really interested in reading on this, send me an email. Transient visual obscurations, fancy term there, but weirdness in the visual field is how I interpret that. Pulsatile tinnitus. So this is I got this on a board prep question at some point. It's pulsatile, okay? When I ask patients, it's more of a whooshing pulsatile. Whoosh, 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 okay? Whether it's one side or both seems to kind of vary. And but yeah, the pulsatile is an important point. Photopsia, or floaters or flashes. I don't know the difference between this and obscurations. Does anyone? All right. Retrobulbar pain, diplopia, and vision loss. So vision loss is the one that really worries us with this condition. This is why patients get placed on Diamox or other therapies to decrease intracranial pressure, because they do lose their vision. And it's not an easy problem to fix once they get to that point. I work very closely with neuro-ophthalmology, and they'll examine for papilledema. I think it's important that we all know about this, but the other thing is you can't use papilledema to diagnose these patients when they're seeing us usually, because it's been shown that the degree of papilledema doesn't correlate well in patients with CSF leaks, so they don't usually have it. Okay, so their pressure is being dissipated presumably. Definitive diagnosis would be by lumbar puncture. Let's get into a little bit of the imaging relationships with this condition. So first question, what is the sellar diaphragm? Okay, you could say the roof of the cella too. All right. What is an empty cella, Julia? We're going to edit that a little. Anthony, you just liked the word obscuration, didn't you? Yeah. Okay. Paige, any more detail there?
I think that about something.
Anyone want to? Close. Very close. Perhaps let's go through some old school anatomy diagrams here. All right. So sagittal of the cella, they're calling this the sellar diaphragm. So that's the dura. See how the dura splits and goes along the along the bone of the cella, and then you've got this layer forming the roof. But if we look, the infundibulum has to go through that dura. So there's a little hole here, and so then what happens? Although I haven't seen a great paper on this, but I've heard enough people say it that I believe it. You get herniation of the arachnoid, okay, and then that brings the subarachnoid space into. So here's my lovely diagram again. Here's the dura of the sellar diaphragm, arachnoid above it, herniates through the infundibulum region, and that's how you get filling of the cella. So at least that's like a tangible way to think about it. Whether it's truly always this, I cannot speak to that. But any questions? All right. All right, so yes, on sagittal for a T1, you're going to see darkness in the cella. The pituitary is being squished against the cellar walls. We already said that the arachnoid then is occupied below the cellar diaphragm. By the way, Dr. Ide, if you have any other knowledge on this topic, I am all ears. Have you heard anything different? Yeah, that's what I always thought too, except as I look at more MRIs, I think the cellar diaphragm might actually still be, there might still be a roof there. But I agree, like I don't actually know 100%. And then I'm just showing this. This is a patient I saw yesterday in clinic, actually. So you see bright T2 in the cella, and then look, there's the little infundibulum right there. Okay, and then there was a meningocele we're going to be treating. Okay, what other MRI findings are consistent with IAH? We're going to make you all very prepared for IAH questions on the boards. Jolly, just give me one. We already got empty cella. I'll tell you there are two more that come to mind. There's probably more too, but so don't think. Yeah, I know what you're thinking, but unfortunately, it's the opposite. So there's another one that's easier. That one's actually tough to diagnose. I'll show you some pictures, and you're like, yeah, I'm not going to pick up on that. But there's another one that we can all pick up on. All right. So dilated optic nerve sheaths. On T2, you're going to see more brightness around the optic nerves. Okay, so that's just one other thing. And then this is my meningocele patient. So there you see, again, bright on T2. So it's transverse sinus stenosis is the big buzz term, and there's a number of centers doing transverse sinus stenting. It's interesting, and the people who do it, like we have someone here that does it. So if we get more of these patients, we could probably study that. All right, that was all the background. It's time to learn how to diagnose this condition. So patient presents to your office like this. How do you work this person up from history and physical through to the end? Good. Any other symptoms that make you more concerned about a CSF leak? Yep, good. Those are all good things to ask. So that's the history. And then Raven, if you had to give us an overarching concept of, all right, you have a suspicion for a leak, what's the concept behind diagnosis? Anybody read a source last night? Talks about like the buzz terms for, I'm going to call it the conceptual framework of diagnosis for this, but 2 words, confirm, then localize, okay? So if you think of those as the concepts, then you find the tests that do each of those. Okay, so I like Beige's history. History is very important. I will tell you, self and physician-reported, quote, CSF leaks are not reliable. If you have a partner that doesn't manage CSF leaks and they say, hey, I got this patient, I think it's a leak, it's a 50-50 shot whether it's a leak. So we, the people that are going to manage it, which may or may not be you in the future, but if it is, you have to be the next level of care that asks the right questions to develop that suspicion. Or you will be taken down a rabbit hole of diagnostic problems, we'll call it. Okay, like I said, history is going to guide the workup. So the history, like Beige said, unilateral is huge. It is extremely rare to have bilateral CSF leaks. Yes, it happens, but you have to manage a lot of people to get your first bilateral CSF leak. I think I've had 2, maybe 3. So it's clear and thin drainage. This is important. It is not thick, goopy clear. I've seen a number of these cases where they send it to me for unilateral clear drainage. I talk to them. It's like they have allergies and it's like goopy stuff. CSF leak is going to be watery. Positional is huge, although not totally specific because a lot of people with runny noses, when they lean forward, it's going to drip. Straining is also one. These are all things that are going to increase or decrease your suspicion, but they don't slam dunk it for you. Salty taste, I put a question mark here because there's very little published about it. It'll be in our upcoming paper, but it's, as we all sort of joke about, it's not that reliable. And then, do they have a history of head or surgical trauma? Okay, these are all things that will increase your suspicion. Things that are less likely CSF. Bilateral. Thick or colored mucus. Triggers. If they say every time they eat food, spicy food, coffee, the classic non-allergic triggers, it's going to be a little less likely, right? That's CSF. Not saying it's 0%, just these are the things you want to think about. Now, based on that level of suspicion, we have to then confirm and then localize the bony and or dural defects. All right, next question. I'm not asking Will. Let's see. Let's go with Anthony. What do you think the incidence? Patient presents to your office with unilateral clear drainage. What do you think the incidence is that that's CSF? All right, so Will, I credit Will. We did this together, but he did the lion's share of this by far. So he reviewed like 3,041 charts. And we identified, these are all from my practice over 5 years. We identified 146 patients that had unilateral, clear, thin drainage based on HPI. And I'm pretty good about always documenting that. Here's what we found. It's 30 in my practice, but close to 20. So CSF leaks 30%. Now, I don't think this has been published before, so I find this interesting. I often was told throughout my training that unilateral clear drainage, it's CSF until otherwise proven. I've heard it talked about at meetings, so I think this is a thing. So for ENTs, I think it's good to know that not all these patients are CSF, okay? And what you see here is that nearly 50% are non-allergic rhinitis. This is going to mean something toward the end of this talk. Now, we'll go back to diagnosis. So confirming nasal CSF. How good is the HALO test? Kyle? Oh, come on, it's amazing. No. Isn't that messed up that I could have convinced you of that? Yeah. No, so I want to say the sensitivity specificity is in the 50-ish% range, but I can't quote a paper offhand. This is why it's, so amazing. This was not CSF, something that I don't remember at what point in my life somebody dropped something with blood on a piece of paper and it did this, so I took a picture of it. So it's just not that helpful. All right, so beta-2 transparent. We got to talk about this. What is it? Good. All right. I had to put this on there to look really smart. Neuraminic acid. What am I talking about? So this is a pretty darn brain-specific desialylated isoform. What that means is it's losing neuraminic acid residues. Okay. This only matters if you want to learn about what happens with the electrophoresis that we're going to talk about, and if you want to learn about false results, which Dr. Ide and I are delving into. So yes, you find it in the CSF, the aqueous humor, and the perilymph. But unless you have a communication with those two areas, it's pretty darn specific that if you find it in the nose, right, it's probably brain fluid. It's metabolized in the liver. For testing purposes. Now, the literature, I see all kinds of numbers, from 0.5 to 2 cc's. I've talked to our lab extensively. They take a micropipette of fluid and put it on the electrophoresis. They do spin it down and concentrate whatever you send. But they've told me over and over, they're like, if you can get us 0.5 cc's, this is plenty. Okay, so you don't need to torture people and tell them you have to get 2 cc's. And yes, every year I hear a story from a patient that their doctor told them, if you can't collect 2 cc's, it's useless. Okay, so that's not true. You don't need that much. It takes about 5 to 8 hours on average. Now you might be thinking, well, what is that? It never takes 5 to 8 hours. Well, if you do them on site, I don't know about every institution, but here we run them once a day. They run them at 9 a.m. And they're done actually shorter than that even. They're usually done by about 12, then somebody has to read it. So we have a system in place where it is guaranteed to be read by the next morning. And if it's not, they get a nasty gram from me. A pleasant nasty gram. But it's been an ongoing QI project for a while. The problem is most sites, I think it's the majority. I don't know if you have another, they send them off-site. And in Italy, if Dr. Sabine's watching, apparently it can take 2 to 3 weeks. That's not cool. Now, if you read the most recent review article comes to mind, they'll show these ranges. Okay, so it is a very good test, 87 to 100% sensitivity, 95 to 100% specificity. But if you actually delve into older literature, you're going to find bigger ranges too, and some of them are like in the 70s range. So I think it'd be useful to do some updated studies on this. It is pretty cheap, $70 here, but then I randomly found a place where it's $140. I don't know what to describe it, but either way, it's not like thousands of dollars. What type of lab test is this? Is it you just hand the nasal fluid, drop it in a container, and pops up positive or negative? Good. Immunofixation gel electrophoresis. But this is a qualitative test. We're not actually measuring concentration of the beta-2. Why does this matter? Well, because this one looks nice and pretty. All right, so to give everybody some basic science refresher here, the anode is where it's positive. The cathode is where it's negative. And I know there's someone in the audience that thinks it's the opposite, so it's okay. It's okay if you do. The beta-2 transparent, remember, it loses neuraminic acid residues, right? So it's going to be less negative. So it's going to stay closer to the cathode. So it separates from beta-1 transferrin, and you should see 2 lines, okay? And it's just good that we aren't the ones reading this, because here's a result that I always like to show from our lab. And I was like, hey, can I get the result from the electrophoresis? And he sent this, and I was like, whoa. This is not helping me. So I don't know if it's every site has different nomenclature for the lanes, but they don't make any intuitive sense to me. This patient leaked from her nose on post-op day 2. Lanes ELP and G are the patient. And then each one has a different designation. So it's very, if you don't have them send you a legend, you have no chance of reading this. But the reason I show you this is because look at the blue line. ELP and G are the patient. And then K is the control. So you see a nice, pretty beta 2 there, right? And clearly concentration does affect the brightness of this immunofixation. So my point here is that there is some qualitative aspect to it. If you don't have somebody that reads these a lot, you can imagine how you could get false results. Okay, so you collect this fluid. How long is beta 2 transferrin stable? You're not wrong, right? If you read back in 2011 and you saw Ben Blyer's paper, which is great, he had six specimens, 4 were from lumbar drains, 2 were from nasal fluid, room temperature, refrigerated, all positive 7 days. And then that has been taught, rightly so, that 7 days it's stable. But I had a couple patients, one at Penn I remember, and then some early on, where they had it sitting around for longer and it was still positive. So we did this study with the lab here. We had ICU patients, lumbar drains or EVDs, same storage methods as in Blyer's paper. All were positive 14 days. So we measured them at time 0, 7, and 14 days, all positive. So it seems that it's positive for 14 days too. So somewhere between 1 to 2 weeks. So the point here is not to get caught up in the number of days. It's just that patients can hold on to the specimens for a bit. The lab, variably around Henry Ford, was telling patients if they had it more than 2 to 3 days, then they were just canceling. They just threw the specimen out. Again, this gets back to multidisciplinary collaboration. If they don't read our literature, they're not going to know this stuff. So we have to teach them, and vice versa, hopefully. So false positives, false negatives. Dr. Ide and I, Dr. Ide's in the audience, we're looking into this. Seems weird, right? We talk about this test being nearly 100% sensitive and specific. So I'm just going to rattle these off so we can get to more questions. But chronic alcohol use has been reported. It's a little unclear, the mechanism, and it's a little unclear how much alcohol one has to have before you consider it a false positive. Cirrhosis is another one. Certain bacteria have a neuraminidase. So they can cleave those neuraminic acid residues that we talked about. And then there are genetic variants, although I then found papers that show the genetic variants that are out there. There's like 20 of them. They shouldn't cause a true beta 2 line, but the bottom line is we should know that. It's one of the reasons places require you to get a blood sample. False negatives, mucus. Go figure. So that's why this is not an evidence-based statement yet, but I do tell patients now, don't blow your nose into the tube. This is just anecdotal, but I've had 3 patients, where they were a leak, but they blew their nose into the tube. The first time we collected it was negative, and then they all turned positive after. I don't know. I mean, there might be something to it. And one reason might be that it's been shown that strep pneumo, which is obviously a fairly common bug in the nose, can cause false negatives. Anyone heard of beta trace protein, Anthony? So it's abundant in CSF. Okay, minimal serum and urine concentration. One of the nice things about it, you need very little sample. That's something that's written in the literature a lot. And it takes 15 minutes. And it's also inexpensive. So it sounds great. And here's the data that's out there from 2002. They had 30 patients with CSF leaks. They compared beta 2 to beta trace protein. And you'll see beta 2 transparent, very good, 93 to 97%, but then they showed beta trace was 100 and 100. So I've shown you all these advantages. Like, why don't we use it? Well, I think we tried when I first got here, and I learned very quickly that we can't get it in the United States unless you're probably have some kind of study set up. So we couldn't obtain it, but it's in Europe. I don't see much published on it in the last few years, so I don't know if just most people just can't get it or what the deal is. Do you know? Yep. And beta 2 is pretty solid. And just so you know, I don't know if you'll ever be tested on this, but renal failure patients, it does cause elevation and potential false results. And then it's been shown that it can be decreased in bacterial meningitis. So let's go into another confirmatory study. What do you know about radionuclide cystronography? What is it? If anyone's curious, when I first got here, let's see, who's most senior? Matthew, since you've been here, have you seen this? Okay, so within my first 2 years, which probably matches up with your, okay, they were doing this a lot. Like, I was pretty routinely seeing patients who had been getting this done. And IR was just calling the on-call junior resident here to come and place, or they would send the patient up to ENT clinic, place these pledgets. I don't even know if they knew where the middle meatus and sphenoethmoid recess were. Olfactory cleft would probably be a confusing thing for some juniors. The bottom line is they were placing pledgets, IR run the study. And I was seeing nosebleeds from it. I was seeing like a number of complications from it. A septal perforation once, okay? Yes, it's intrathecally injected through a lumbar puncture. It's either indium 111 or technetium-99, and we're looking for radionuclide extravasation. 2 to 3 pledges is what I've seen in a few papers. This picture is very elaborate. It shows 4. Good luck to a junior resident getting 4 pledgets in those spots. Okay, so then it's variable in the literature. They say they'll remove the pledgets anywhere from 3 to 24 hours later. That seems sort of confounding. The pledgets are compared to serum levels of the radionuclide. And this is all then detected by a gamma counter. All right, so you have to have all this set up at your institution. The cystonogram images are taken at 6 and 24 hours. Isn't that an amazing image? I hope everyone knows what that arrow is pointing at. No? It's okay. So when might you use this? I'm going to call this, I'm sorry for those listening that love this study, but it's just kind of a crappy confirmatory test. But in the literature, it is a form of a confirmatory test. So it's talked about in intermittent leaks because you can have these pledgets in there for some amount of time, right? But obviously, that's going to depend how long you keep them in. If you keep them in for 3 hours, you still might not catch it. So I think the problems with this is it seems to be variable how it's being used, okay? Some other patients, that story, they just can't quite collect enough, or you just feel like this patient's not reliable. I've heard that as an argument from people who want to get like the patients that you're just not really sure it is, so let's just do a radionuclide cystronography. I'm going to make an argument that that's not the best option. It gives poor anatomic localization, as Lane said, other than the side. Why do I know anything about this? I talked to Marin, who then put me in touch with someone. Apparently we have like 2 people in Michigan that feel comfortable enough to use this study. So it's very user dependent. I'm not going to go through all this. You guys get the idea. You measure the amount on the pledget. But the part I want to show you, you're looking at the ratio of pledget to plasma radioactivity. A normal, and I only found this in this study. It's definitely not ENT related. So normal 1.3, positive is if it's greater than or equal to 1.5. Okay, but then there's a subpoint. Marked asymmetry, also suspicious if it's not greater than 1.3. I don't feel like this has been replicated a whole lot in more recent studies. And my personal example is somebody was a positive and read by one of the people in the state that does this test, and she ended up not having a leak. So I'm obviously jaded by this. These are the amazing images you can get. As you see here, it is obvious activity in B here. If you can't see it, you have failed residency. But yeah, it's just, there's a lot of dots there. I'm sorry. I don't see it very well. All right, so a recent IFAR evidence-based reviews back in 2016, sensitivity of this test. Again, you see these ranges that look so glorious, 76 to 100%, specificity 100%. I take issue with this since we had a clear false positive. And they say the diagnostic accuracy is 90%. The cost, though, is not cheap. It's $2,800. Compare that to $70. And so their conclusion was because of its high cost, the fact that it's lower sensitivity than beta 2, and it's invasive, and I've already told you, this is not a pleasant thing. People get nosebleeds, hopefully not septal perforations, but that actually did happen. And then, so they recommend repeat beta 2 transferrin testing. And I think that's a good point in general. If you get a beta 2 result, you don't have to live and die based on that first beta 2 result. You can get another test rather than get this radionuclide. And then if you're still unsure, I'm going to show you benefits and risks of intraop exploration. And so you might want to consider that rather than put people through this radionuclide. So we've talked about confirming, right? Beta 2, radionuclide. Let's talk about localizing now. What's the first imaging study you want to get in a patient with a confirmed CSF leak? High-res CT, you're going to want 1 millimeter cuts or less. You're looking for a bony defect, for sure. Like you got to have the bony defect, right? But you have to also have that mucosal defect and an arachnoid defect to get the leak. Not all defects are CSF leaks. So it's not uncommon, especially with age, to see sometimes multiple sites of thinning, and that can be a little frustrating. Criteria that might suggest it, we just mentioned it. If you see this situation, you've got a tiny little bony defect, but then this sinus is opacified next to it. Again, it's not a guarantee, but it might make you want to get a different study to see what that opacification is. And then air, this is subdural or intraparenchymal air. But you can have epidural air that is not a CSF leak. We've seen it a couple times here. Brain tissue herniation. Not always obvious, but if you see a huge defect and a nice round thing sticking in the nose, that's a little suspicious. What can be done now to determine if a bony defect on the CT is in fact a leak site, as in arachnoid and dural defect as well? What do you inject for a CT cystonogram? Jupna. Oh no, I've thoroughly confused everyone on purpose. Okay. So there are different things we inject for all these different studies, and I don't know. It was a board question or a prep question at some point, so I want to make sure everyone's clear on this. The radionuclide, those are the isotope ones, indium or technetium. CT is the simple one. It's iodine. It's like any other CT with contrast, all right? The fluorescein is a different thing altogether, but we'll talk about that. Okay. All right, does that make sense? We're straight? I mentioned why these are helpful, so we won't go through this again. This might show you whether there's a true dural defect at the bony defect. In a situation that comes up, tons of skull base fractures, let's say, or other multiple defects, you might get a cisternogram to show where there's leaking through it, or if you have bilateral defects, things like that. And then this came up for me recently. Somebody had a prior sinus surgery. They had a bony defect. She's not leaking, but there's this very suspicious area in her ethmoid cavity, and lo and behold, I just got the MRI back, and it is a meningocele. So that'll tell me, like, I'm going to be careful around that area. In CT, iodinated contrast, so a situation like this is a situation where I'm going to argue you do not need a cisternogram. If that patient's leaking, then you don't need the CT cisternogram. Okay, but this is what it looks like. You get the iodine contrast lighting up the meningocele. All right, so what are the downsides to CT cystronography? It's invasive. It's a lumbar puncture. It's annoying for patients, not only because it's painful, you have to set it up, you have to go there. They position you in all these different positions. So it also requires an active leak. This is a very commonly reported downside in the literature. So if you catch somebody on a day where they're not leaking, it's negative. It's also annoying to read. I've talked to radiologists about this. I've looked at the scans because when I got here, they were doing a lot of these as well. And if you have leaks in the olfactory cleft, it's not easy to find. So it does depend on the leak site. All right. What's MR cystronography? Heavily weighted T2 image, fat suppressed. So it's non-invasive. Hopefully they do multiple planes, but you get a picture like this. Okay. You're looking for tissue herniation or CSF filling there at the site of the bony defect. It's non-invasive, so you don't need the lumbar puncture. You don't have to do IB contrasting either. In the recent IFAR review, they suggested this could technically be both confirming and localizing. I think for your purposes, you should know that cysternograms on the whole are for localizing. But if you think about it, if you don't have a beta 2 and you had a situation that was amenable to this kind of imaging, you could see how a heavily weighted T2 image could be confirmatory for a CSF leak. It does still technically require an active leak, so all these cysternograms are limited by that point. Let's say you suspect a CSF leak, but the patient can't collect enough fluid for beta-2 transferrin, and the cysternogram is equivocal. What else can you do to either confirm or localize a CSF leak? How do you use fluorescein? Yeah, so it's another intrathecal injection, but no imaging to follow it. Some of its risks, I'll say 2 big ones that we should know about. Neurologic, I'll say it's neurotoxicity of some sort. Seizure is the big one. And then there's some old reports of paralysis and things. Let's go through this. So again, it's intrathecal injection, endonasal visualization. This is going to show you potentially the sites of leaking. I really like it when you have multiple bony defects. I trust this much more than cysternograms in my experience. Bilateral bony defects, it's also nice when you see one side fluidly leaking fluorescein and the other side's not. So it's going to improve not only the intraop visualization, but also confirmation of sealing of your repair. It feels nice when you see all the yellow, you put your graft or flap on, and oh, there's no yellow. Okay, because sometimes there's some clearer stuff floating around that kind of worries you. One big point that we got to consent these patients because this is not technically FDA approved. We're supposed to educate them that there have been reports on these complications we spoke of. What are those complications? They're based on older literature. 1997, there was this huge study, 925 patients, 3 patients had seizures. 2004, 420 patients, 2 patients had seizures. But I think it's important to note what the concentrations were being used. Okay, so in 2004, a milliliter of this was being put in 2 milliliters of water and then injected. So that brings me to my next question. What dosage of intrathecal fluorescein do we use now? You go to pharmacy and you ask for 1% or 10%. So textbooks and series that you'll read will say 0.1 milliliter of 10% fluorescein and 10 milliliters of CSF and inject this slowly over 10 minutes. I was taught that as well. Here at Henry Ford, I think all of us now, we give 0.1 milliliters of 10% fluorescein for sure, but it's in whatever number of mLs you want of CSF, and you inject it however fast you want. Ask us how many seizures have happened in 7.5 years. 0, okay? Obviously, I work closely with neurosurgery. They had no concerns about injecting this fast, but sitting there for 10 minutes without evidence behind it, why are we doing this? So we did this. We're going to be presenting our numbers at North American Skull Base this year. If you don't see fluorescein leaking intraoperatively in somebody who was beta-2 positive, what do you do? So you talk to your neurosurgeon, they're like, no, we injected it. Nothing came back. We flushed it with 20 cc of saline or something. It's all good. Let's talk about exploration in general, because this is not really talked about in the literature a whole lot. In that patient, when you scope the person, do you stop at the scope? You don't see any fluorescein, call it a day, or do you do surgery? Yeah, I mean, these are interesting dilemmas. Hopefully you've done that's why I said when you take your history, you do all your diagnostic workup, you put a lot of thought into why you're going to surgery, and hopefully your suspicion level is high enough to warrant this, because you can run into this. And I'm going to show that there are unfortunately problems in both directions of the decision making. My argument is do the sinus surgery, because I've actually seen some fluorescein come through hours later. If you wait for hours and then decide to do surgery, that's just like a total waste of everyone's time. Open everything up, and obviously you're going to focus your energy at the site where you saw a bony defect. And this comes down to how comfortable are you operating around the skull base and identifying a CSF leak. What do you do? This is a little bit of the art of medicine. We do know, though, there are at least 3, maybe 4 papers now looking at the accuracy of this. So this was a retrospective chart review. 56 patients got no intrathecal fluorescein, 47 intrathecal fluorescein. False negative rate was 26%. Okay, so this is frustrating, but you just have to know this. You just have to know that almost every step of the game with CSF leaks, there's uncertainty. So when you go in, if you're pretty darn certain based on the history and everything that this is very, very likely a CSF leak, you got to do a little extra work. Valsalva patients, do whatever you got to do to try to stimulate that leak. I think it's a good test. I think looking back at our numbers, we're about to run our internal sensitivity specificity, and it is accurate most of the time. So you will usually see it. It's just not perfect for sure. So what do? I say the art of medicine. You're going to restudy the scans. So you take a break from the case, you go look at the CT, the MR, whatever you have, think about the history, consider those reasons for false results. I've had false positives, okay? So now that I know those exist, I'm a little more diligent about retesting beta 2 pre-op, because you just don't want to be in this situation. It's not fun. So do you wait longer? Trendelenburg the patient, Valsalva, and absolutely, it might be magic, but I swear there's at least a couple of cases where we put the patient in crazy Trendelenburg and did the rest of the case. I was opening sign and it came through. So again, I think this needs to be studied better. What do we do for intraop exploration? And just more about why. Why do we not always see fluorescein coming through? We've definitely injected fluorescein before during like florid leaks and not seen it come through. So there's something. So the issues that we're talking about here, it's not perfect working up these CSF leaks. Okay, you're going to have multiple times where you're like, wait a second, that's positive, that's negative. But the patient had this in their history. It doesn't make sense. They could have had a false positive, false negative. So each step is problematic. So how could we fix this, or potentially? So I want you to think back to this idea that not every unilateral clear drainage is a CSF leak. About a third. It's legit enough to where I always collect unilateral clear thin drainage. I give those patients a test for beta 2 if they can. I do feel better with a negative result, and sometimes it'll show up positive, and you're like, oh, okay, we got to do something about that. But I think it is important that we realize maybe half of these people don't have a CSF leak, so we don't need to put them through a radionuclide cystronography. This is a slide that Will Mason and I made for our North American Skull Base talk a year ago. Yes, still, absolutely, we got to try to get beta 2 collected. When it's positive, it makes us all feel better. Yes, they're false positive. It's pretty darn rare to be false positive, so we're going to explore those patients. Or you could argue retest the beta 2, because I've had a couple turn negative, but we won't talk about that. I think the tough thing is when it's negative, or the patient says, I'm sorry, I just can't collect enough, or the test is read as inadequate. So this is where that clinical suspicion comes in. The yellow star points to this spontaneous systematic review consensus statement was published in IFAR in 2020. It gets back to some of the symptoms we talked about. When somebody's purely positional drainage, prior head trauma, sinus or skull base surgery, they've had meningitis, IAH symptoms. These are all things that are making your clinical suspicion higher. So for those patients, we probably want to work them up further. And that's where it's going to get into what you've learned, what you've done, what your institution can do, whether you get cysternograms or explore patients with or without intrathecal fluorescein. For low clinical suspicion, that's when we might think about other types of medical therapy. Do we do further workup? This is a gray zone that's not really teased out well in the literature. We got to keep in mind that all these tests we're talking about, the morbidity as well as the cost of cysternograms and operative exploration, and then we've already shown that there's a range of accuracies. Okay, so they're not all perfect. So what's a potential solution? Well, we like ipratropium bromide spray. So this systematic review was just published by Ed Kwan at UC Irvine, one of our colleagues, and we knew this based on reading the literature from the 90s. He put it all together in a nice, organized fashion. Props to you, Ed, and your team there. Ipratropium bromide spray, highly successful for rhinitis-related rhinorrhea, which is actually, now we know, a common cause of unilateral clear drainage. That gets you thinking. What if we use this spray to screen for unilateral or for CSF in patients with unilateral rhinorrhea? And so we did this study. Phil Nolte left, but he and I worked through this in conjunction with Will's data. Prospective study over 4 years. 113 patients presented to me with unilateral clear thin rhinorrhea. Beta 2 was ordered in all the patients, and then we prescribed ipratropium spray 0.06. CSF rhinorrhea was confirmed by operative exploration. Non-CSF rhinorrhea was a negative beta 2 transferrin, so you had to have a negative beta 2, and then some of those patients, based on clinical history, still got explored, but at least a negative beta 2. We had 53 non-leaks, 20 leaks. We assessed whether ipratropium response predict the absence of a CSF leak. So if their rhinorrhea got better and they didn't have a CSF leak. So here's our results. I won't go through all of it, just the atropine because it was the only one that was significant. So you see, kind of interestingly, similar sensitivity and specificity to beta 2 transferrin and a lot of these tests. And then the specificity and positive predictive value is 100%. Okay, so the odds ratio, the largest I've ever seen. Ipratropium response is 844 that if they responded to Atrovent, they don't have a CSF leak, because none of the people that had CSF leaks responded to Atrovent. No other variables that you see there, the ones that we talk about a lot, right? Positional, salty, triggers, whether they had surgery before, were significant. This just brings up the question, not saying this is at all ready for prime time, but can we use something as simple as a nasal spray like ipratropium to screen for CSF leaks in patients presenting with clear thin rhinorrhea? And so we're presenting this soon in January 2023 at the Trilogic meeting in San Diego. In conclusion, after we take the history and we're suspicious for a CSF leak, we confirm with beta 2 transferrin for now is the best starting point. It's very good, but as I've shown you, it's not perfect, so you do have to think about false results. You get the CT sinus to localize. Rarely are you going to need cysternograms. If you do need one, an MR cysternogram is a good one to go with. It's non-invasive. And you just type in the comments, please get T2 cysternogram sequences. Intrathecal fluorescein, nice option. Have to be familiar with how to do it, have somebody to place a lumbar drain and such. But we have to keep in mind the false negative rate, 20 to 30%. And in the future, maybe we add ipratropium to the paradigm to rule out CSF leaks. Time will tell. Thanks.